Well, guys, I want to thank you for joining us today on our podcast. I'm excited to have David Long. David Long is a great friend of mine. I've known him for a long time. He's a friend, he's a colleague, and he is a trusted advocate for the healthcare center in Lubbock. David has opened up his practice, Lubbock Cooper Health, for quite some time. It is a thriving practice, which he takes care of a tremendous amount of patients. So, David, thank you for joining us on the podcast today.
Right on. Thanks for having me.
No, my pleasure. So why don't you tell my audience a little bit about kind of what you do, what your practice is like, and what type of patients you have? What is it like to have a primary care practice? What type of patients do you see?
Yeah, well, I'm board certified in family medicine. So, I see kids all the way up to elderly, everything in between. So that means continuity of care. I'll do their annual exams or manage chronic conditions like diabetes and hypertension. But we also have an urgent care clinic. So we're open to walk-ins. If we're open, you can be seen that day. We have our own x-ray machine and lab here. So it's kind of one-stop shopping. Plus, we have a drive-up clinic to help patients find easy access where they don't have to get out of their car. And then we also do occupational medicine. So injured workers, their employers can send them to me and I get them back to work as soon as we can. So it's kind of eclectic, a lot of different things that we do here.
So, David, obviously your practice encompasses a lot. And so what is a typical day like for you? So when you go into the practice, first thing in the morning, what is it like? And what is your kind of typical day as in your practice?
Sure. I get here and we hit the ground running. And the truth is, one of the things I like about family medicine is honestly, I don't know. I might have an annual exam, or I may have somebody with an ankle sprain, might have an injured worker with a laceration, might have somebody that wants to do a hormone consult. So I get here, I take the first chart on door number one, and I roll in and see what the day holds. Since we're an urgent care clinic, a lot of people come to me on their lunch break. And so we're open during lunch, and then I just grab something to eat when I can. Then there's 4 providers here. We're open till 6 p.m. So one of the providers stays until 6. And usually I'm seeing patients till 4 or 5. And that's it. You never know what the day may bring. A lot of urgent care, a lot of continuity, a little of both. Yeah, it's exciting.
Gosh bless you for doing primary care, because I am not even close to being as smart to do primary care. I have to do something dumb like GI, where it's just one thing and I scope and that's it. So thank goodness for people like you who have the intelligence and the patience to do that. Thank you.
Sure. Well, thanks for the compliment. I like it. I get bored easily, so there's just so much breadth of what we do, and you just kind of figure out areas that you're comfortable in, areas you're less comfortable in. You don't try to be a cowboy and manage the things that I don't have any business managing, and I have a low threshold to refer on those items. And then other things that I feel more confident in, maybe I'll keep and take care of more here in the clinic.
Now you mentioned, urgent care and hormone optimization, but you also do preventative care as well, right? Like what exactly is the difference between urgent care and preventative care, so my audience knows?
Yeah, that's one of my favorite things. So preventive care is the patient that comes in and says, Doc, I feel like $1,000,000. I'm just here to be sure I am as healthy as I think I am. Because, a 22-year-old probably doesn't have a whole lot of necessary primary care. But as we get older, we need to screen patients, which of course means you feel fine. If you're
Yeah.
having bleeding, gastrointestinal bleeding, well, and you need a scope, that's no longer a screening colonoscopy.
Mhm.
That's a diagnostic one. In the same way, I don't need people to come in just when they have complaints, but once a year, we do a head to toe exam. We'll get some blood work, a diabetes screening, maybe check their hormone levels, check their cholesterol levels. And the good thing is that real insurance companies are mandated that they have to cover that for free once a year.
Wow.
And then beyond that, there are some other ancillary items like an EKG to check your heart, or a chest X-ray to check your lungs, some nerve function testing we can do that some companies, some insurance companies also cover those for free. Now, it's not just out of the
Wow.
kindness of their heart that they do that. They've crunched the numbers, and in their financial interests, they want to avoid hospitalizations. So they're willing to
Yeah.
cut things in the clinical environment here because it saves them money in the long run. And so I tell patients every day, your interests align because you want to stay healthy, they want to save money. So they incentivize patients to go to their doctor and get a checkup. And that's really what
Yeah.
we do mostly. That's our
It's shocking to me that, I hear that preventive care and these screening tests are covered by insurance companies, because you're right. That's one of the difficult things that I think a lot of people, a lot of patients don't understand, is that prevention is what keeps you from living longer, living healthier, and not
right.
having to go in the hospital. So I think it's very surprising to my audience that they don't even realize that they can come to someone like you and get all this test done and
Yeah.
it be covered by insurance.
Yes, and we check. So the Affordable Care Act mandated that the actual uh, office visit portion they all have to cover.
Hmm.
Then after that, well, this Cigna covers this, and Aetna covers this, and Baylor Scott and White covers this. It's a list of maybe an EKG and maybe a chest X-ray. So we by now we've learned which insurance companies cover what ancillary testing, and if someone doesn't have a specific need, maybe they don't have asthma, their lungs are fine, and we would only do a chest X-ray if their insurance covered it for free. We're not looking to run up a big
Yeah.
bill. So yes, the office visit's free for everyone. Then after that, we pair it specifically with their insurance plan to be sure that they're getting whatever is covered for free on their particular plan.
So let's say, it's somebody like me, for example. Let's say I'm a 45-year-old man. I'm otherwise healthy. I work out. I have some family history of some cholesterol and heart issues. I'm feeling tired, a little fatigued. Now, I don't know why. Let's say I come to you and say, hey, Dr. Long, I feel tired and fatigued, but I'm worried about making sure I live longer and healthier. Like, how would you approach somebody like a
Yeah.
patient like myself?
Sure, of course, that's a very common complaint and a long list of things that can cause fatigue. But if it's someone, I'm a little older than you, but I'll insult you by putting you in our group, some our age group, who comes in with fatigue. The first two things I think about are, well, tell me about your hormone levels, right?
Mhm.
Or had it checked. And the other thing is not necessarily how much are you sleeping, but how restfully, how restored
Mm,
sleep. What's the quality of your sleep? And that has to
yeah.
do oxygenation and keeping your airway open so that you can get down to those restful deep stages of sleep rather than just constantly snoring or having obstructed breathing all night long where you're just barely asleep keeping having to clear your airway. But the hormone part, I tell people every day, it seems normal to you and I to live to be 75 or 80 years
Yeah.
old. That is not normal. That is very new in human history. From the
Yeah.
beginning of humans, whenever that was, until science showed up about 2,000 years ago, everyone here was dead before they're 35.
Yeah.
And 5 out of your 12 children were dead before they were teenagers from
Yeah.
malaria, cholera, starvation, exposure, right?
Yeah.
And that's all natural, incidentally, that Americans like to think is so safe. But really, it's science, it's water sanitation and agriculture production and neonatal care for little babies that's tripled human life expectancy. But we have to remember, it tripled human life expectancy on a body that was literally designed by nature to be done before I'm 35.
Yeah.
In the same way, I can drive my pickup truck for 600,000 miles if I want, but of course it's falling apart. It was never designed that long. Of course we're falling apart. We were never designed to last past 35. So what happens is sometimes patients will get their hormone levels checked,
Yeah.
and this is the normal range. And a guy comes in way down here, the doctor typically says, well, it looks good. You're in the normal range.
Yeah.
But to heck with that. If I don't feel well here and I can safely feel a lot better up here normal, let me try
Yeah.
it. That's the idea of hormone optimization. So a guy with fatigue or anyone with fatigue in that age group, I would say let's check your hormone levels and see if there's room to improve it safely. And perhaps let's check the quality of your sleep. And then I do some other things like, diabetes screening and checking and be sure kidney and liver function are good. But that's where I would target. That's what I would really focus on for that patient.
So hormone optimization, this is very interesting because we see a lot of things on social media, on the news, just things that you see about, optimizing your hormones, improving your testosterone. I
Sure.
feel like there's a lot of misinformation out there, but that confuses the public about what exactly should I, as an individual, look for in terms of symptoms that would make me think, hey, I think my hormones are off. I need to see someone who can optimize that. So besides fatigue, what are some common symptoms that other patients may think, I think I need to get my hormones checked. Like what should they be looking for?
Well, it's kind of, if we're talking about optimizing hormones, there's three that we would be looking at: thyroid and testosterone for both men and women. We optimize testosterone levels in women more often than men. Not the same,
Hmm.
of course; they don't want hair on their chests, but a little bit. And then estrogen, and that would just be for women. So if we're talking about thyroid, fatigue, metabolism problems, perhaps some constipation, some problems with skin, hair, and nails, those are
Yeah.
things that immediately think they may need some hormone optimization in regards to the thyroid. Testosterone has a long list, but it was actually surprising to me to learn that the number one thing testosterone does for men and women is improve the quality of your sleep. So I
Wow.
don't know if testosterone directly improves mood and memory and energy levels, or if those just get better because, of course, they did. You're sleeping better, but who cares?
Yeah.
So,
Yeah.
a loss of strength, maybe a decreased libido. Some of these things are commonly associated with low testosterone. And then the estrogen, you have to be careful. You want the right aged female where she's either surgically menopausal, she's not bleeding, she doesn't have a uterus, or she's old enough to be through that. Then we would look for hot flashes, some emotional changes, perhaps some vaginal dryness. These are all things that we can help with safe estrogen optimization.
So those symptoms seem to be very, it's hard to know, obviously, on the symptoms, which patients are actually under optimized with their hormones versus something else. And so, what is kind of your approach? Because it seems like everyone would fit that category. And so I'm wondering, are we are we overdiagnosing hormones, or are we actually underdiagnosing or not realizing the effect that these hormone levels are, because we don't really quite know how to manage somebody who's on the lower side of normal, even though they're quote unquote normal?
Gosh, yeah, that's a great question. So I tell people, I'm 49. I would tell another 49-year-old, it would be very strange for your testosterone level to be great at 49. In the same way that it would be very unlikely that I would drive on a single set of tires on my truck for 60,000 miles and have big old thick tread on the tires.
Yeah.
Yes. At 49, I'm already nature's been trying to kill me for 14 years. That's how much longer than 35 I am. So of course my testosterone level should be low. But
Yeah.
that doesn't necessarily always equate to those symptoms. For instance,
Mm.
see somebody, man, I feel like $1,000,000. I sleep like a baby. I've got energy for days. I feel strong. I would say, I do not care what your testosterone level is. We're not touching it because
Yeah.
your quality of life is so good. But if
Yeah.
you have any of the symptoms on the list, which correlates with a testosterone level that could be safely optimized, you try it. And if you like it, you do it again. If you don't like it, you don't do it anymore, right? It's
Mm.
science. But of course, at the same time that I'm getting their blood work to check for their hormone levels, it's also going to screen for diabetes. I'm going to check a PSA level to
Yeah.
be prostate irritation. So if there are other really significant reasons why that patient might be fatigued, we would find that during
Yeah.
this workup for their hormone levels. And I have had lots of patients where I said, yes, your testosterone level is really low, and we should look at that. But also, you have raging diabetes, and we have to fix that first, and then we'll your testosterone. So you got it has a place, a seat at the table. It deserves some consideration, but definitely
Yeah.
it gets trumped by some other things that would be more dangerous. Because tell patients every day, nobody dies in the parking lot
Yeah.
because your testosterone isn't optimized or because your thyroid isn't perfect.
Mhm.
So it's a soft sell. If they don't have symptoms that match in a low level, we move on.
Well, I think it's important I think it's a very important point, because I think too many people, even us in the healthcare, we don't look at the global picture of the patient. And you're exactly right. That's the great thing about preventive care that you offer, is that you are looking at everything. You're looking at their hemoglobin A1C, their risk factors for cardiovascular disease, their sleep, and their hormones, and you're using your medical judgment to make the right decision based on what you're seeing as part of that preventive care package, but also offering that option that if their hormone levels are maybe not the best and you think that's the reason or a driving force, it could be an option that you can offer them, but not limited just to that.
That's
That's
right.
fantastic.
Not limited to that, and we'll know pretty soon. You try it, and if it doesn't make a precipitous, appreciable difference quickly, then move on. Let's do something else. And of course, there seems to be an unnecessary distinction that I think is based in marketing, that
Mhm.
either doctors tell me to, care about me and listen and talk to me about diet and exercise, or they don't listen, they just want to throw meds at me.
Yeah.
And both of those are ridiculous. We
Yeah.
definitely want to look at eating healthily and nutrition and stress reduction. But let's remember, sometimes it is that absolutely synthetic medication that is the reason you're not going to have a stroke in the parking lot. So
Yeah.
put together out of the, all natural group versus the completely synthetic group, and put together what's right for the unique person sitting in front of me. We should not paint with broad strokes here. We need to go, the major issues addressing the unique individual sitting in front of me, and let me put something together for that person, rather than just telling them, meds are bad or too many medications, this and that. No, let's tailor something specific for that patient.
So how do you balance that, David? Because it's a hard balance because you're right. Us going through med school, we were taught the medical treatment, the medications, the diagnosis. We weren't taught a lot about some of this prevention in terms of sleep,
Right.
nutrition, fitness, hormones. And so, A, how did you come to that knowledge? And then B, how do you kind of merge the two to
Right.
treat the individual individually as opposed to, a textbook, so to speak?
Yeah, my impression is that it wasn't necessarily ignored when we were in school learning about pathology and pharmacology and microbiology. It's kind of like, yes, yes, we're going to assume, student Dr. Long, that you are talking about nutrition and exercise and stress reduction and meditation and whatever it is you want to talk about. So we're going to assume you're doing that. Let's talk about all of these complicated medications and their interactions and outcomes that we're looking for. So yeah, I did have to kind of go back and go, no, wait, I'm going to talk about treatment approaches, but let's not forget that the foundation of this should be consistency in your lifestyle, consistent exercise, consistent deliberate approaches to stress reduction and nutrition. And so I don't know that we need books and books and books, although there's fantastic books on nutrition and diet. Pretty much, if you told me, hey, David, clean up your diet, I could go, yeah, probably less. I don't necessarily need to read volumes of books on dietary information to know that. And if somebody else is obese and not feeling well, eat less. I tell people, let's dumb it down. If it's white, don't eat it. Red pasta, sugar. You start there and you're going to make eat the reds, the greens, the yellows. You're going to make some pretty significant health changes just with that. So you're right. It is a marriage of both. Let's start with the foundation of nutrition, exercise, and stress reduction and sleep hygiene. But yes, occasionally some patients are going to need some medicines. Just like if I plan to keep that truck on the road for 600,000 miles, I'm not just going to begrudge having to get a new transmission and new brake pads. I'm not doing that. You can run that truck smooth into the ground if you choose to. Or if you're going to keep it on the road way past its expected lifespan, it's going to need a little help, and that's okay.
Yeah, I think too many of us in the medical field, I think we try to be, I wouldn't say too smart about nutrition, but we kind of are sometimes. You're right. I think we kind of know what not to eat and what to eat. Most people know that going to McDonald's every single day is not good for you.
Not ideal.
Yeah, exactly right. And most people know if you eat more vegetables, minimize the bad carbs, minimize the whites, minimize alcohol, you're gonna eat healthy. And I think that sometimes we get a little bit too dogmatic about a certain diet. You have to be paleo, you have to be carnivore, you have to be vegetarian, as opposed to just doing simple, easy advice that most people know, because that way you can at least give patients the option to pick kind of whichever route they want to go down, but at least give them the general knowledge about,
Right.
eat healthy. Most people kind of understand what that means.
And I think our assumption that patients already kind of have that box checked, and then we kind of move on to where we can help on top of that, has led to there being a community of people that assumes we don't care about that at all. And
Yes.
at all. And we should probably spend some more time there. But to suggest that that's the good approach and all these medicines are a bad approach is a binary
Yeah.
assessment that is just not accurate. We need
Yes.
a combination of the two most of the time.
Yeah, that makes a lot of sense. A lot of sense. So obviously in primary care, you are dealing with a lot of the GLP-1 medications. They're everywhere. Patients are on them. Patients are asking for them. There may be some confusion about that. And also, I'm sure there may be some other options that are out there besides using some of these GLP-1 medications. So what has been your experience in primary care with the rise of these weight loss medications? How has it
Yeah.
been your experience with your patients?
Well, I'll tell you what, we've had some weight loss approaches come along in my career, and it's always kind of an assessment of relative risk. Okay,
Mhm.
the risk of the medicine for this patient versus what's the risk of them not taking this medicine. And
Yeah.
I'll use the same example. The seatbelts. Are seatbelts safe? Absolutely not. A dozen people die every year because their seatbelt killed them. But could I use that information and reasonably say, well, don't wear your seatbelt? Everybody knows they're not safe. Oh, relative to not wearing the seatbelt, it's not even close. And in the same way, what weight loss medicine are we talking about? Is it bupropion for depression that's also used for weight loss, or metformin that's also used for diabetes? And
Yeah.
some patients get really hung up on that. He gave me an antidepressant. That's crazy. I can't take that for weight loss, which is the same thing as saying everybody knows Tylenol's for fever. You can't use that for back pain. Well, yeah,
Yeah.
you can reasonably use a lot of medications for multiple things. Anyway, we want an assessment of what's the risk versus what's the value. And they've kind of been pretty close for most weight loss approaches. And now we have the side effect or risk side of GLP-1s is so low and
Yeah.
potential benefit is so high that I have a much lower threshold to prescribe them. Some of the others, it would be only if you're, morbidly obese and
Yeah.
your risk factors of heart disease, diabetes, and high cholesterol are such that we've got to do something. And now it's like, hey, I'd like to lose 20 pounds for my, kid's wedding that's coming up. All right, why not? I know I'm not going to hurt you, and I
Yeah.
start with do no harm. So let's go. But yeah, they're
Yeah.
real game changers. I think the peptide approach to treating conditions, I don't think it's an understatement to say it's going to revolutionize medicine. We're sort of getting the first dose, so to speak, here in the diabetes slash weight loss realm, but these are not going away. This is not a flash in the pan fad like some other things.
So what can you expand on that? What you mean by that? So what do you mean as this kind of being the first approach? And so where do you see, because I agree with you, this has been a sea change
Yes.
in healthcare. I mean, these conditions that were driven by metabolic derangements and obesity
Mm.
are virtually going to be gone. And so I'm curious as to where you see this going and how this may change the approach for primary care and medicine.
Well, there's you can use peptides for all kinds. There's peptides that'll give you a tan now, and there's peptides that can help with recovery and strength and these kind of things that athletes could use, and maybe post-operatively we could use them if we can demonstrate some improved healing. One of the really exciting things about tirzepatide in particular, which is the generic for Manjaro, as you know, and Zepbound, is that when a medicine suddenly starts being used on just broadly, like it was for weight loss, sometimes we find things by accident. The way this medicine works, or it works in such a way that it quiets food noise. You're just not
Mhm.
craving, not eating lunch thinking about your afternoon snack, or it's afternoon and you just are constantly thinking about medicine. It quiets that. But it's been used in so many people that occasionally you're using it for someone for weight loss who also happens to be an alcoholic, or they also
Wow.
happen to have an, and what they are reporting back is, yeah, doctor, the food noise went away. Also, I don't drink anymore because the thought of I just take it or leave it on their drug of choice. It
Yeah.
decreases. So the implications of the use of these medications in addiction and recovery is really fascinating because again, the safety profile is such that you're not going to hurt them. And two, if
Yeah.
it turns down the craving noise, whether it's for food or for drugs of abuse, it's really exciting. Just one example.
Wow, that's amazing. So have you have you
Yeah,
have you kind of had patients who've experienced both, where they had, the food
absolutely.
cravings went down, but some of the other addiction or tendencies went down as well?
Yeah, absolutely. I've got lots of friends that probably drink a little bit too much and they wanted to lose a little weight, and they'll come back and say, "Yeah, I don't think about food all the time, and I'm down 25 pounds and I feel great." And also, seemingly unrelated, I'll have a drink or two a couple times a week, and I'm
Yeah.
content with that. It just doesn't appeal to me like it used to, and that's
Wow, that is
fascinating.
fascinating.
Yeah, and that's anecdotal,
Yeah.
which is worthless. It's pretty close to worthless, but not quite worthless. We need some good science to demonstrate that that's actually factually supported by the evidence,
Yeah.
but we had enough reports that it is worth a closer look to see if there's a place for this in addiction and recovery.
Wow, that's fascinating. I think that that's an exciting realm for medicine that we just haven't gotten good treatments on. It's so hard to break the cycle of addiction, whether it's alcohol addiction, smoking addiction, or whatever. And to have a medication that we just happen to find that can maybe break that cycle, I think you're exactly right. It may be the impetus to change another sphere of medicine that we'd even realize we had the opportunity to change.
Right? Yeah, weight loss was just a side effect they noticed with some of the GLP-1s all the way back to Byetta in the early 2000s. And now it's just gotten better and cleaner, fewer side effects, works better until we got to these last GLP-1s more recently. And yeah, it's really exciting to see where this might go.
So you mentioned that you guys offer a drive-up clinic, which is very interesting. So tell me exactly, like, do you literally just drive up to your clinic and get care? How does that work?
Yeah, it's really fascinating what we learned from COVID. Of course, there's still lots of information coming in. We'll be learning about COVID a lot, but one of the things that we as providers had to learn was how to pivot quickly to meet the demand of the community.
Mhm.
And one of the things we did was we don't have enough exam rooms to meet the sudden need for patients to get tested or retested or whatever. And so we set up spots in the parking lot for us to send our staff out to quickly test patients. And then when I built this clinic, even though it was sort of towards the end of the pandemic, I thought, why does that need to go away? Because it's wonderful. It
Yeah.
helps separate the sick from the healthy. If someone's here for their preventive checkup and they feel great, they would prefer not to sit next to two people with the strep throat, right? So it gives
Yeah.
me 4 exam rooms on the south side of my clinic where a patient just drives in. There's a big plaque on the wall that says, call this number and we'll come out to you, take your vital signs, do any testing, swabs if you need it. Then the provider comes out and sees you and we can get you out quickly. And you didn't have to come in and register and sit in the lobby. It's also really convenient for those with small children. Maybe they don't want to entertain their kids in a boring doctor's office. And so they can just sit in the car and watch their movie. You can work on work or homework or whatever. So patients have the feedback we get is that patients love it. And I like it because
Wow.
again, it helps separate the healthy from the sick. And selfishly, I've got 4 more exam rooms that I didn't have to pay to finish out. Right? There's no furniture out there. It's selfish, but it's great, so everybody's happy.
That's great. So is it mainly for urgent care visits, sick visits? Is that kind of what that those patients should be aiming for?
Any upper respiratory things, you can imagine if somebody's got really bad knee pain or a back pain and I need to examine them, that's tough to do in a dry
Yeah.
situation. Or if they're there for their annual exam, it's not really made for those. It would be something that you would go to an urgent care clinic for your coughs and colds and allergies and my ear hurts or strep throat or I think I've got pneumonia. And occasionally we'll have someone drive up who's sicker than they need to be in the drive up, but we just walk them through the back of the clinic and then can examine them in house. But yeah, that's typically the patient we're looking for in the drive up.
Wow, that's fascinating, but also I think you're right. It allows that separation for people who are healthy from those who are sick and contagious, so that you're not, just spreading germs everywhere in the waiting room and
Right.
all throughout the practice, which could be difficult for patients, but also for providers because we get sick as well.
That's right. Yep, we get sick as well, and the staff like it because they can run out there real quick and see a patient unless it's 20 degrees. We do shut off if it's below about 25 degrees because it seems unkind to make my staff stand out there in the cold vital signs. It's also tough to get an accurate temperature when it's 20 degrees and you're just sticking a probe on their forehead. It tends to underread what the patient has when you're standing in blizzard conditions.
Oh
But
yeah, that's true.
other
That's hilarious. Well, David, if a patient wants to come see you for urgent care, for primary care, for preventive care, for the drive-up clinic, for hormone optimization, what is the best way for them to get in contact with you, to find you, and to have you be their doctor?
Well, great. Yeah, we're wide open to we're establishing care with new patients every day. And so if somebody wants to come and establish care where we are their provider moving forward, they would call and make an appointment to establish care or get an annual exam. And the phone number is 806-531-3977. Or if somebody wanted to just roll in, they've never been here before and they think they've got strep throat and they come to the drive up clinic, we can take care of all of that, at the time. They don't have to have an appointment. Website is lubbockcooperhealth.com, and they can go there to get more information as well.
And so, what is the address for your clinic? Where's it located at?
We are at 12115 Indiana, so
Perfect.
122nd Street. And
All right, so David, so you did something very impressive is that during COVID, during a time when things were crazy, not only did you open up your own practice, you built your own building and you established kind of your whole practice. So
yeah,
tell me, what were you thinking doing
What
it
they,
during that time because you picked like the hardest time to do it.
yeah, I tell you what, I think that's the most important question to ask. What are you thinking? What's the why behind you doing this? There's a lot
Yeah.
of reasons going to private practice, and some of the, yeah, it was very nerve wracking, but I had a bit of a sense of peace because I wasn't necessarily going to greener pastures.
Yeah.
This was not about, I bet it's better over there. This was, I am unwilling to continue doing what I have been doing up to this point. I could go live in a tent and be a fly fishing guide in Colorado and just, have just a song in my heart and a smile on my face. So I thought, but I'm going to give everything I have, of course, to make this work. But that was what I was thinking was, I think it'll work. I don't think I'm going to be the first of about 8 family medicine doctors who went into private practice who just doesn't make it. So the trail has been blazed by some other colleagues of mine who were braver than I, because everyone after the first could go, well, he made it work. Surely I can do that. And I was in that list, but I was just crazy enough to take some, degree of security in my profession or my career, and kind of put that on the line. And because of my team, really, I have an outstanding team, and got a great location, and a good patient following. It worked. I sure am grateful for it.
So team, that's a very interesting, that's a very important part of developing a practice, developing a team. So I've been to your practice. You have an amazing team, you have an amazing practice, and obviously you're the leader of that. So how does one, how do you develop a team like that? Like, how
Uh,
did you do that?
Well, of course, there's seminars and books and courses written on, team building and whatnot, and everybody's situation is unique to them. Mine was that before I left the clinic I was at before, I brought in some people that I would love to have work with me, and I just said, hey, would you be willing to consider leaving this job and these great benefits and this security in your job, and come join me in private practice with no real safety net, but let's give it our best. And to a man or to a woman, every one of them said, absolutely, sign up, let's go. And I think that of course, that didn't just come in a moment. That's because of the relationship that I have with these
Yeah.
people I work with, that I care about them, and I was able to communicate that to them over years, and they were able to watch me be successful in my last clinic, and thought, yeah, he's going to make this work, and I want to work with that guy. And I think that's, so I was fortunate to be able to build a culture of 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 a very positive workplace environment where we kind of enjoyed each other. Our work family got along really well, and so again, every single person that I suggested, hey, maybe would you be interested in coming with, they all said yes, which made me think, hey, I think maybe this is going to work. They said work. So yeah, that's how I built my team. Was most of them came with me, and that is the strength of our clinic, I think.
Absolutely, it really is. And so you mentioned kind of relationships and developing these relationships with the people who you worked with. And so, do you feel like that capability for you to have that closeness with them and for them to feel like they can trust you with their career, with their families, and with their livelihood, like how are you able to just do that? Like I'm trying to selfishly figure out, how does David Long be such a badass leader? Because I want to do whatever you're doing. And so, like, what have you done? Like, have you have you been in positions like this before? Like, what is your secret sauce to be able to do this? I'm really curious about this.
I'll
Because
tell you
I'll
what.
tell you, so really quick, I'm gonna tell you, just my audience, like David is not just a leader in his practice, he's a leader in the medical community. Like I'm telling you, it is awesome to see this guy work. He is, it's so impressive. And like, how do I be like this guy? So like tell me about this. Like, how did you learn this? What kind of got you these skills?
Gosh, my head's going to get so inflated I can't even get through the door. For those kind words. It's my personality to be engaging, and I
Mhm.
have to leave some in the tank for my people here. And what that looks like, of course, I'm giving to the patients, I'm serving the patients. We're all here to serve the patients, but that can't happen if I don't have a little bit left in the tank for my staff. So I get here and I'm asking Abby, how's she doing? uh, how's your boyfriend? Is he acting right? And then I'm asking Clarice about her children. And then I'm asking my x-ray tech, about how she's doing. Not all of them all at once, but I just take opportunities to just touch their lives personally where that they know that it's not just coming to collect a paycheck,
Yeah.
serve Dr. Long. And I don't know that it makes any difference, but I really, it doesn't matter if it's a provider or a nurse or administration or front desk. These are people that I work with. This is Daisy, that I work with Daisy. It's not, hey, this Daisy, she's my employee. Or, this is Clarice, she's my employee. No, this is Clarice, I work with her. That this is a team. And I think being consistent in that over a long period of time gets some buy-in on their part. Yes, and then occasionally we'll go to the range, the little bar behind my clinic, and we'll have team building happy hour, right? Or we have a Christmas party every year, or we have a fantasy football draft party every year. So those kind of things that I think also result in some buy-in. But I've never read a book on leadership. I've never been to a seminar. I really don't know beyond that.
Well, that's good. I think, too many of us who are business owners in the medical field or anything, we get sometimes just too caught up in the nature of the business to really understand that our staff is the secret sauce, and just knowing, who they are, their, what kind of lives they have, their personal lives, just making that effort to know them as a person
Yeah.
will probably bring more dividends than anything else you can do.
Really does. And so sometimes what that looks like is if there's inevitably a patient gets upset with a front desk person, and I'll go and I'll talk to them, and then I almost invariably tell the employee at the end, hey, that didn't go well. The next time do exactly the same thing. You were right and they were wrong. Right. I want them to know that you are
Yeah.
important to me even more than a single patient. I'm gonna do everything I can to defend why you did what you did. And also, you need to know that I'm going to set a boundary for some kind of abusive behavior or
Yeah.
just zapping their energy and their time. I advocate for the employee in that situation. And that really means a lot to them, too.
Yeah. So, you mentioned before in the very beginning that, other people kind of, blazed the trail for you before you did. I think there's like a very common misconception. I see this with medical students and maybe some residents coming in that, private practice is dying or in trouble, or it's difficult to do. And obviously you've been successful, and so have other people as well. And so what are some common misconceptions that you thought of or you heard about that you realize that now that you're in private practice, it's really not true?
Yeah, boy, gosh, I really could write a book about that, I think. In my experience, most of the people are going, gosh, whew, all these private practices just, drying up left and right. They're probably a hospital administrator that wants you to work for some clinic feeding mothership hospital. Just that people most likely to say such things.
Yeah.
But so I said a minute ago, my team is the secret sauce. The other secret sauce, and I don't know if this is unique or it just feels uncommon, maybe it's not, but almost every private practice family medicine guy around here, we all trained within a few years of each other, and we
Yeah.
are each other friends to some degree.
Yeah.
So
Yeah.
all on paper, I'm competing with Dr. Tran down the street. He calls me every time. He says, hey, there's a new code. You need to be using it. Hey, I just got a better deal for supplies. Here's who you need to talk to. Hey, have you ever tried using these home sleep studies? And if I have things that I come across that are working to help patient care or help the business side, I call him. And then we call
Mm,
Dr. Owens. And then we let Dr. Shanklin know. And then we better tell Dr. Carrion.
mm.
So we're sharing ideas because the private practice community, we're all very fiercely individuals, and we appreciate our autonomy. We're also a team, or we start
Yeah.
picked off by larger groups that want to come in and kind of take over the practice that isn't doing well. And so, yeah, when we come across something that works, we help each other out, and that's been very useful.
Yeah, I think people would be surprised how much camaraderie there really is amongst the independent physicians, because it is a different ball game when you're out there, because it's not necessarily that you're competing against each other, but you're competing against maybe a different entity, and we're all kind of on the same team when it comes to that. That makes a lot of sense.
Yeah, yeah, that's exactly it. If one of us, if there are less of us, we all become weaker. If we are trying to stand strong against a large entity that would like to come and pick us off and purchase these practice at below value.
Yeah, yeah, you're right. Let's talk about really quick culture. So I have this obsession now where I've been just obsessed with culture and how to develop culture and to kind of form culture. So what do you feel like is kind of the culture of your clinic, and how have you tried to mold your clinic to the culture that you're hoping to get?
Good question. It's lead by example there, and what that looks like for me is if we're short on nursing, I tell the head nurse, or now they all feel comfortable enough to tell me, Dr. Long, get off your rear end. We need some help, because they know that I'll give shots. Hey,
Mhm.
I'll get this patient. I'll do their vital signs. I'll bring them back, rather than me sitting here with my feet up on the desk, watching YouTube videos while my
Mhm.
staff is drowning. You're in the trenches with them, and that really builds a culture, and also not just that they appreciate me helping, but they go, gosh, if he's willing to do that,
Yeah,
I had better do the same, or I'm going to stand out. And so it
yeah,
kind of raises everyone's professionalism.
yeah,
And then there's a culture of fun. We've got music playing, and people are discussing things when we can, when we have the time, about their children or about their activities or whatever they're into. And also the other providers, the other leaders in the clinic, Kristen Garrison, Stephanie Garcia, Wesley Otto. These are just wonderful human beings, and you love working with them. You love working around them. So, picking your team carefully is important, and then nurturing it and showing
yeah.
care builds a really positive culture. Now,
No, go ahead. Sorry, Dave. Continue. Continue.
I was to say that's kind of not a really rehearsed, kind of a sloppy answer. There are, again, books written on this stuff. I never read any of them. This is what works for me is being authentic with my staff and excited to see them, and just gratitude, gratitude, gratitude. I'm so grateful that I have the blessing of working with this particular group of people, and it's not fake, and it's not. The book told me to do that to build a good culture. It's just real, and
Yeah,
they sense that.
yeah. One of the things that I think sometimes can be a struggle for those of us in private practice is, the decision to kind of stay where we are in terms of growth, build what we have, try to optimize what we have versus try to go, grow bigger, try to, have more providers, more clinic space, more and more and more. So do you ever have that kind of that tension between keeping what you have versus wanting to grow more? And then B, if you have, how do you manage that? Because I find myself commonly where I'm like, I love what I have right now, but it'd be nice to kind of have a bigger space to see more patients, take care of more people, maybe add another partner or whatnot. And so, my wife and I always have this discussion about how I sometimes have my head in two different spots. And so do you have that same tension that you've noticed in yourself as well? And how do you manage that?
Every single day. Every,
Good. I don't feel so bad now.
no, because it's not. There's no stress about, oh my goodness, are we going to make it? That was the first 6 months of the practice, and it
Yeah.
took off. It's fine. And so if I knew right before I went into private practice, if I knew that we would be where I am now, I would say, thank you. That's all I need. I'll stay right. I swear I won't ask for anything else. Just let
Yeah.
it at that point. And then you're here and you go, well, nice if I start not working as much. And what would I
Hmm.
do that? So, yes, and as my mom used to say, if you're not careful, you'll get to the point where you ask yourself, how much is enough? And the answer is just a little bit more. And I
Yeah.
get to that point. I want to be content, and I really am. But
Mhm.
right now, I've meeting with the architect because we need to make some more room for more exam rooms.
Mhm.
But that's the nature of business, is you want to grow.
Yeah.
So again, I would ask the why behind it. Is this just to chase more dollars at the expense of some of your quality of life in time?
Yeah.
Do you still have the time you need to nurture and take care of your family? And then balance that with the economic forces. What's the trajectory right now in your area of growth? And you got to look at those metrics as well. But yeah, it should be a little nerve wracking, and it is for me. I'm kind of waist deep in that right now, trying to figure out the timing on that.
Okay, well, I don't feel so bad now. I'll tell my wife that, hey, David's doing these things as well. So you can't blame me for it. It tends to be a universal thing for all of us.
I'm in it right now for sure.
Well, that's great. Well, David, I know it's late. I took up your time, man. Is there anything else you want to talk about in terms of private practice? Things that we didn't mention on this part of the podcast, David?
Not necessarily. I think we covered most of the high points.
Okay. All right, man. Hey, man, thanks for your time, buddy.
I do.
I appreciate it.
Yeah, anytime, buddy.